love is too high to bring me down. Can't nothing bring me down. I said, because I'm happy. Clap along if you feel like a room without a roof. Because I'm happy. Clap along if you feel like happiness.
Welcome everybody to our power lunch today, where we're going to focus on pharmacy. So 2 weeks ago, we did innovations in medical care. And today we're going to spend the full hour together talking about the technological advancements in treatment for pharmacy. We could probably spend 10 hours on pharmacy, but in our hour together today, we're going to talk about the new genomic treatments. I have some videos incorporated so that we all understand what the new genomic treatments truly do for us, and how they're life-altering, they're life-saving. Some of the new advancements in medicine with pharmaceuticals, the biopharmaceuticals, are life-changing, but they're extraordinarily expensive. So as you sit on the employer side, it's great to know that we're solving diseases, but the cost is extraordinary, millions of dollars. So today we're also going to focus on how to make sure that we keep them as affordable as possible. I'm excited today because I have a partner joining me from our pharmacy department. Shannon LaBar is our expert. She's great at saving companies money, but more importantly, improving the quality of care and outcomes with clinical programs. So we're happy to have her insight today because we all know that pharmacy is a very important part of our benefits package. It's attributable to about 50 cents on every dollar that we spend on medical and pharmacy. And the new specialty treatments, although they're only 2% of utilization, they're about 50 to 60% of our spend. So we're going to spend a little bit of time talking about those today. When you think about how much our industry has changed in the technological advancements in the last 3 to 5 years, it's extraordinary. We used to go to the pharmacy and get chemical flat pills in a bottle from the pharmacist and take them as directed. And now we have specialty drugs that are most often living organisms. They're biopharmaceuticals, and they require special refrigeration and special administrations. Most of them are injectables, and they're very expensive. So let's get started, and I hope you enjoy our session today. Well, let's get started. We have several hundred employers on our webinar today joining us. Just goes to show you how important pharmacy is as one of the top spends for your health and welfare programs. To level set, we just wanted to take a quick minute. Tryon is a division of Marsh. Marsh McLennan Companies is the largest brokerage consulting firm in the world. We're sister companies with Mercer, Guy Carpenter, Oliver Wyman, and Tryon really focuses on health and welfare for employers. So your medical, your pharmacy, life, disability, vision, and dental, that's kind of all we do. And we really try to stay at the forefront of the trends, really looking at not what's just happening right now, but what's going to be happening in the future to position our clients and employer partners, the buyers of healthcare, in the best possible position to be aware of what's coming and prepare as much as possible. The pandemic has definitely gotten us sideways, and we're not out of the woods yet, for sure, in the all-top sweatpant bottom world of Zoom and webinar and working from home. But one thing that has affected employers and spend is the dip in utilization due to staving off employees and their families putting off getting medical care. So in the first 2 quarters of this year, we've seen a significant drop in claims because elective surgeries have been canceled. And even, our employees and their families have put off getting well care. In some cases, important cancer care, cancer checks, preventive screenings. So we do feel that we're going to see a boomerang effect with the utilization and our claims in the second half of the year, probably in the last quarter of the year. hopefully when we start reopening safely and get a vaccine for this virus. So we will see probably claims tick up. Pharmacy is definitely going to be at the forefront because we have new emerging therapies and medicine coming to market that we're going to talk a little bit about today. Today we're going to talk about pharmacy, today's challenges, really understanding the new drugs and the new therapies coming to market. That's probably the most complicated piece of what's going on in pharmacy, is really understanding what a pharmacogenomic is, or a genomic editing drug. So we're going to walk you through that. We have some really cool videos to share that really make it simple to understand this complicated stuff. Certainly want to talk about technological advances and solutions that employers can use to potentially have better outcomes, cure things. But the problem is, at what cost? So some of these advanced treatments solve, child muscular atrophy or muscular dystrophy. We all watched Jerry Lewis telethons back in the day, and they've come up with a cure for almost a cure. It basically stops the progression of muscular atrophy if caught early. Could mean the difference between a child walking in his lifetime and not, but at the cost of $2.2 million. So certainly something that we struggle with as employers and payers. And then we're going to talk a little bit about solutions and strategies. As I said, I have Shannon joining me. She's the subject matter expert, and she's going to help us walk through some of the tough discussions today. The first part of the presentation is really kind of going to be setting the table with understanding what's going on in the marketplace, understanding healthcare technology and how things have changed, and certainly how we can, by better understanding those items, make our plan design based around clinical programs and clinical outcomes to drive better cost and better care for our members, for sure. We will see more change in the next 5 years than we have in the last 50. If you hadn't tuned into my previous Power Lunch, we have a recording of it, and it really talked about the changes in the marketplace and how technology and big companies like Apple and Google and, of course, Amazon are changing the way that healthcare is delivered in the United States. We all have to be aware of those things because we're the buyers, right, on behalf of where most Americans get their insurance coverage through their employer. So we want to make sure that we know how the marketplace is changing and keeping up with those changes. So we're going to kind of move right into the marketplace disruption. Shannon's going to cover a little bit of this in our question and answer session that I've set up for her in a minute. But if you look at what's happened since the end of 2017, what's happened in the marketplace is the medical carriers have teamed back up with the pharmacy carriers. So in our marketplace, we have companies like CVS, Aetna, where Aetna handled medical insurance and they used CVS as their PBM, their pharmacy benefit manager. But now it's one company because CVS bought Aetna. And same thing with Cigna and Express Scripts. And what that's doing, and of course, United Healthcare, the largest insurance company in the US, owns OptumRx, so they own their own PBM. And Anthem invented last year, developed their own PBM called Ingenico. So if you look at the marketplace, all of the major medical carriers have pushed back together with pharmacy. And you really sit back and you have to wonder, why would they do that, right? Why would CVS want to have Aetna? The video we shared 2 weeks ago really talked about how integrating the two could lead down the path of better end results and care, because it would be an integrated process. Moreover, I think what we're seeing as the consultants to employers, the payers, it's really about controlling the front end of care. So what CVS and Express Scripts and OptumRx and even Amazon with PillPack are trying to do is they're trying to devise ways to garner the primary care physicians, the front end of the care delivery system, to get you kind of a captive audience and buying prescriptions through them. So definitely one of the things that we see is Walmart, CVS, Walgreens, and Amazon are even moving into primary care, right? So if you look at CVS, they've pushed out retail space and they're opening health hubs, which is an expansion on their minute clinics. They're really targeting the millennials and the Gen Zs and the Zoomers in the fact that they don't want to get healthcare the way that we have in the past. They don't want to access healthcare by waiting 2 months or 3 months to see a primary care physician because they're so backed up. So what Walmart, CVS, Walgreens, and Amazon have determined is there might be a better way. If they open up these health hubs and there's primary care physicians or physician's assistants that can see people immediately on a walk-in basis, they're hopeful that you walk to the back of the store and get your prescription filled at the end of that visit. They really want to control the whole healthcare ecosystem, so to speak. Shannon, can you share with us a few of your thoughts about the marketplace consolidation? I know when you talk to a CVS or a Cigna and they're talking to employer clients, they talk about all of the integrated benefits, right? So they tout to the consumer or the employer that putting the pharmacy together with the medical results in lower cost because it's a more integrated approach for disease management and clinical management and other things. But we haven't seen that in the marketplace. As a matter of fact, we've seen the opposite. So with our clients, when they carve out to a PBM, like an ESI or an OptumRx or a Navitus or any of the marketplace PBMs, we feel like they get better pricing and more focused approach to clinical programs on the pharmacy side. So I'd be interested as a clinician what you think about that.
We anticipate that the combined organizations will make carving out the pharmacy benefits less attractive through improved pricing being passed along to the employer or through the market-wide restrictions, like in some markets where employers with less than 500 or even 1,000 employees are not allowed to carve out or being required to carve back in. That's been the interesting piece in all of this puzzle. We have also seen a lot of insurers increasing integration and reporting fees in an attempt to keep those pharmacy claims carved in. A lot of plans are starting to see that hit financially through their ASO whenever they're carved out. The reporting fees can be quite significant, as well as any type of accumulator fees. So we're watching that one pretty closely as well. Tryon's pharmacy practice still has the stance that we can see significant savings that are available to employers by carving out their pharmacy benefits. Contract clarity, things like your AWP discounts and your pricing terms are still very low-hanging fruit that a lot of plans have not utilized in the past few years, and we need to really start pursuing better rates for those plans.
So based on what Shannon just shared, and thanks Shannon for that, it really is a big concern of employers, not only that there are an impact of new $1 million treatments coming to the market and quite frankly are already here, but the impact of the conglomerates, right? So the fact that the PBMs and the medical carriers are coming back together again in an attempt to control the marketplace. I would say that employers under 1,000 employee lives, it's tougher for them to negotiate than, a big 50,000 life company, right? So a 50,000 life company has the leverage. They have the ability to go to the carrier and say, no, we're not going to do it your way. We're going to do it our way. A 500 life group doesn't have that, the luxury of that buying power. So we're seeing that when the medical carriers teamed back up with the pharmacy carriers, it really has eliminated the option for smaller employers to shop around for pharmacy benefits. And that really could cost employers, quite a bit. The end result is anti-competitiveness. So just to kind of back up just for a second, because I know we're laden with jargon and things, but when you carve in your pharmacy, that means the medical carrier manages your pharmacy too. So it's all in one. It would be like Aetna CVS, where you have your pharmacy and your medical managed by one team of people and one carrier. Carving out is something that we've seen really to the advantage of the employer being able to carve out and get special pricing and being able to negotiate clinical programs that they wish to deploy to get better care for their members and lower cost. But when you carve out, you're having a second carrier. So you have your medical carrier managing your medical claims, and you have a pharmacy benefits manager managing your pharmacy claims. So that's just kind of the carve in, carve out question. And we're going to talk a little bit more about that in the next coming slides. The high cost of specialty drugs are certainly a concern for employers. We have 3 drugs that are on the market that are genomic medications. They're pharmacogenomics. So they are basically living organisms that will change somebody's DNA. We're going to talk about that in a minute. But it's Zolgensma, which came out the middle of last year, and that was to treat muscular dystrophy. And again, it's given hopefully in the first year of life, and it staves off the progression of muscular atrophy. The second one was a retinal dystrophy drug, Lexturna, and that came out towards the end of last year. And again, that is a genetic altering drug. And then we're expecting the third to hit the market in the next month. So it's supposed to be the end of August if they're still on track. The pandemic has kind of put them back a little bit. But that drug, Roxtevner, I don't even know how to say these drugs, but it's a hemophilia drug, and it's quite substantial. So it's actually going to help the body clot where a hemophilia wasn't able to have the right makeup in their blood to do accurate clotting. So life-altering, really crazy progression and positive movement we've had in the development of life-altering treatments. 61% of injectables are concentrated among 20 drugs that are specialty drugs, and 5 of the top drugs are oncology, so cancer drugs. So they're very expensive, and I think you can see over on the right-hand side of the screen, there's 40 to 60 emerging gene therapies that are going to be launched by 2030. So the tsunami of these huge, expensive drugs are coming. The great news is it's going to cure or treat diseases that were untreatable and uncurable in the past. But we're left kind of sitting here thinking, oh my gosh, how do we afford these drugs in the plan? Stop loss is one way to protect yourself. So 26% of all stop loss claims are due to the cancer drugs, those top 5 injectable specialty drugs, very expensive drugs. There are some new to market solutions that are coming out with really the gene therapies and the cell therapies are anticipated to be a large influx in the next couple of years, and that's going to really affect employers and our cost. But some of the gene therapy products that have come to market were because employers were sitting back and we were saying, hey, listen, we can't afford more of these $2 million therapies and drugs that are covered under our medical plan. Because if you look at the utilization, and we look at utilization, every day. So if you're looking at calendar year-end utilization from 2019, you can plainly see, and it's across the board, it's 90% of employers, that 5% of their people are spending 90% of their dollars, and it's because of these specialty drugs. There have been new to market solutions. So CVS has one with Aetna. It's a stop loss solution. Cigna has teamed up with ESI, their new integrated platform. Their new solution is called Embark. And of course, Tokyo Marine, a stop loss carrier, came up with a solution as well. They're all different and they're apples and oranges, so you can't really compare them. But basically, in a nutshell, what they're doing is it's taking the Zolgensma, the Luxturna, and the hemophilia drug that's coming out next month. And they're saying to self-insured employers, we're going to remove those from your risk pool. So as a self-insured employer, if somebody goes to get Zolgensma for their child, it's not going to be under your self-insured plan anymore. It could be fully insured through one of these carriers. And they manage the drug, they manage the cost, and they manage the treatment protocols. So it's almost like fully insuring these three things. There's differences between them. We're trying to get our arms around how they work, what's covered, what's not, looking at contracts. These are brand new to market in the last 3 months. So we'll probably, my guess is that we'll have a power lunch seminar in the next month or two once we've digested these options, to give you a lay of the land, to say, here's how they're different, here's how they're similar, here's the pros and the cons, to help you understand them. So I want to stop for a second and get Shannon's opinion and pick her brain a little bit about what she sees as employers' top opportunities for cost savings. So out of all of the things that we've talked about, Shannon, what is the thing that you get most excited about when talking to employers about the opportunity to save money? One of the things that I've heard a whole lot about most recently is the net cost formularies. So we all have heard the PBMs being accused of putting the drugs on their formulary that yield the greatest rebates. And that might not always be the lowest cost to employers. So I'd like to hear from you as the expert a little bit about what you think about that.
Yeah, there are actually quite a few new to market opportunities available to employers to help lower plan spend in pharmacy. The first thing that comes to mind are the new programs available through a few different PBMs to combine the risks. So they're not quite stop loss, but they're being advertised to plans that do not have stop loss insurance today to help cover the cost of some of those high cost specialty drugs that are coming to the market or already on the market. Two of those drugs that are covered in both of the opportunities that are available today are the Luxturna and the Zolgensma. And so basically what that does is it's applying a risk pool for employers to get involved in and make sure that they do not have to pay out of pocket for the full cost of that medication. However, they don't get their money back if they don't have one of those medications in a plan year. So that is an opportunity to mitigate some of the risk that's out there, but at the same time, it is an expense to the plan. The other opportunity that's really gaining traction in the marketplace right now is what we call a low net cost formulary. And that's actually my preferred option that's available right now to help lower plan spend. A low net cost formulary actually does what the closed formulary was supposed to do a few years ago, but those closed formularies have now migrated into something more like a rebate maximization program and less like a closed formulary. So what the low net cost formulary does is it eliminates non-essential medications, or should eliminate non-essential medications from your formulary. And by non-essential, we mean those high-cost, low-value drugs like Duexis and the Vimovo or Absorica. And so all of those medications have alternatives that are available to them, and depending on the plan, you can save anywhere between 90 to 95% off of the cost of that medication. Before rebates, of course, but then so we're looking at about 80% after rebates would be available to the plan. But an 80% saving off the cost of the medication is pretty significant. We're seeing roughly about 10% of claims being impacted by that low net cost formulary. The Duexis and the Vimovo are perfect examples of medications that have availability on the marketplace and a plethora of options available to members over the counter even. And yet the plan is picking up a huge price tag for those types of medications.
So we're going to move right into the pharmacogenomics and really helping you understand what's coming, what's a proven strategy to reduce cost and improve outcome with these pharmacogenomics. So this is a positive thing. They're very expensive, I know, and that's concerning. But these are really fabulous and exciting times that they've come up, that scientists around the world, but predominantly mostly in the United States, have been able to solve and cure some of the most devastating diseases.
Come with us to a new world, deeper than the ocean, as unfathomable as the universe. A world that doesn't exist outside you, but within you. Where breakthrough science is replacing chemotherapy with immunotherapy. Where we can now attack the causes of disease, not just the symptoms. Where medicines once produced for all are now designed to fit you. Today, 140,000 biopharmaceutical researchers go boldly to discover treatments and cures unimaginable 10 years ago and are on the verge of more tomorrow.
That was an exciting video, and every time I see that, I kind of get the goosebumps because it really is about precision medicine and really medication that's designed for an individual. So we're going to go through gene editing and show you and share with you an explanation of what gene therapy is. But gene therapy literally goes into the body and looks for the faulty gene, and it fixes it. It's crazy, but these drugs are gene therapies that will go in and look for what's incorrect, cut and snip it and fix it, so that not only does it cure the disease or stave off the progression of the disease in some cases, but it actually prevents it from being passed down to generations. So they come with an extraordinary price tag. But we all have to be so thankful that they're making breakthroughs. And hopefully someday they aren't so expensive. So as they progress and we expand upon these technologies and innovations, hopefully the cost of them will come down.
To understand CRISPR gene editing, let's start with what is DNA? Handed down from generation to generation, every cell in your body carries a copy of your genetic code, called your genome. It's made up of DNA. It's like a book that describes you, a book made up of 3 billion letters arranged in different sequences that make up DNA words. These words can influence the traits that you take on: athletic, intelligent, gifted. Recently, computers have deciphered the entire human genome and have identified genetic mutations behind diseases that currently have no cure. With CRISPR, we can edit DNA. CRISPR is a man-made molecule that can be programmed to find mutated or diseased DNA. It's also equipped with a pair of molecular scissors. So once CRISPR finds its target DNA, it can snip that section from the genome. Sometimes the body can repair itself. Other times, scientists can patch it with corrected letters. If this happens in egg, sperm, or embryonic cells, the changes will be permanent and passed on to future generations. CRISPR is already showing promise. It's being used to cut out the HIV virus, eliminate Huntington's disease from the brain, and even alter a mosquito's genome so it's less likely to spread malaria and Zika. CRISPR could lead to a new world of treatments, curing diseases and even eliminating them, so future generations won't ever have to suffer from them again.
So I shared that video years ago at a conference, probably 3 years ago when that first came out, and it sounded like sci-fi, right? It really did sound like, Star Trek stuff. And hopefully you all know what Star Trek is. I might be dating myself there. But, if you think about these gene therapies and how far we've come from 2018 just to date and looking ahead, it's significant. And as an employer, we all need to be aware of what the pipeline looks like and what's coming, because we want to get out in front of these. We want to have clinical protocols in place before somebody gets on something so that we're not taking anything away. We're just making sure that there's a good process in place to vet whether the person's actually eligible for the treatment that's, might be $2 million. So we talked about this. This was the Zolgensma spinal muscular atrophy drug that hit the market. It's priced at 2.1, but it's administered in the hospital. So there's another couple $100,000 added to the bill once you get through with the hospital treatment. But it is life-saving. And the hemophilia drug that's coming out next month will also be between 2 and 3 million, and life-altering for hemophilias that, hemophiliacs that may not, as kids, may not have been able to play sports or participate in much because of their condition. That all could be changed in the future. This is really just a pipeline. You're going to get a copy of this recording and the slides so you can take a look at this at your leisure. But the pipeline is robust for the next 5 years, and this is probably not everything on there. This is what we know about. There's a lot in development. And we all have to be ready for August when the hemophilia drug gets distributed or hits the market with FDA approval. Because, if you get one or two of those claimants, that could be problematic for your budget and your forecasting for your healthcare spend this year. The high cost injectable drugs are definitely driving things. We talked about, 61% of the injectables are concentrated among 20 drugs. 61% of people getting the injections for specialty are within these 20 drugs, and the top 5 are oncology. So you can see, the new drugs that are coming out are going to be focused on these categories as well. This is interesting, especially in the last 2 weeks. So we know a couple of Fridays ago, two weeks ago, the Trump administration signed 4 executive orders in regards to pharmacy. And I just, we spent a lot of time reading through what they did release, and some of it was because he held it up and the news people got pictures of it, because a lot of it wasn't released to the public and it wasn't made. It's still private. He is trying to hold true on campaign promises that he made 3.5 years ago to do something about the cost of prescription drugs. The problem with the 4 executive orders is they're kind of toothless. They probably won't get implemented, and there's a lot of caveats to the thinking around what he's looking for, what the Trump administration is looking for, and what could possibly get passed. But employers really would like some help from the government. If you look at government's view of employers' view of government's role in managing these high cost claimants, 46% would like some government involvement in either trying to lower the overall cost of these drugs without inhibiting innovation, But certainly this is something that is going to be front and center in the election. All right, so we're going to move quickly into the strategy section and talk a little bit about what employers' top objectives are. So for 2020 and 2021, improving access to care and medicine is definitely at the top of the list. Lowering overall healthcare spend without sacrificing plans, and a focused approach to high claimants. And in the last Power Lunch we did, we talked a lot about those objectives and some key opportunities for employers to embrace in trying to move the needle on those, right? A prescription for change, so to speak, no pun intended. But if you look at some of the centers of excellence, for cancer, let's use that as an example. It's the number 2 cost driver across the country for employers. Heart and stroke is number 1, cancer is number 2, and diabetes is number 3. And there are places that do it better than local hospitals. They focus, they're called centers of excellence. There's different ways to access the center of excellence approach. Most employers do it through their carriers, where you set up a value-based plan design for your employees and you say, if you do this, we'll give you that. So if you are diagnosed with cancer and you use our Center of Excellence program, and you have a second opinion where physicians review the charts, talk about your path of treatment, and then you might go to a facility that does immunotherapy or some of these new genetic technology drugs that have proven to be more effective than some of the traditional approaches to cancer treatment. We will waive your copay. So it's kind of, if you do this, we'll give you that. So we're going to talk a lot about that when it comes to pharmacy, because there's a lot of opportunities to put value-based plan designs in around pharmacy. Managing specialty spend, we're going to talk, this is just statistical, so I wanted to share this slide with you, but the next slide is really getting into all of the different levers that you can pull. But statistically, prior auth for specialty medication is top of the list on employers' techniques on managing pharmaceutical costs. But you can look at this at your leisure. It just kind of puts in order for you the strategies that employers are doing. This is a save slide. So if at the end of the session, this is probably the one slide that I would say is kind of a checklist, really. So, you want to think about, should we carve out pharmacy to improve pricing and gain control, or should we leave it embedded with carve in with the medical carrier? So that's the first decision. And are you able to? So like Shannon was talking about in her, question answer session, she really hit the nail on the head, because it has become more difficult for groups under 500 or under 1,000 to make the decision to carve out. Utilization management programs, really looking at your data and understanding what's driving cost, what are your top illnesses, what are your chronic illnesses, and then a complete utilization review on what are the management opportunities or levers to pull for those particular issues. Diabetics, for an example, if you have a large population of diabetics, you could say, we're going to put in a disease management program to make sure they're adherent with their medications, and we'll waive their copay if they participate in the program. It is really, really easy with some illnesses to put in some plan design changes that make a big difference in your cost. And it makes a big difference to your members because it's a win-win. So the people with diabetes are adherent with their medicines, and it's easy to pull. So if you look at your chronic illness buckets, they're usually a 90-day supply, right? Because they're ongoing medicine to manage that chronic illness. And you can see the adherence rate or the refill rate. So our carrier partners should be giving you the bucket of chronic illness users or the bucket of chronic illness patients in our population, what is their average refill rate? So on a 90-day supply, it should be, 90 days, maybe 100, but it shouldn't be 165. So if they're getting their 90-day supply prescriptions refilled at 165 days, they're not taking their medicines. Looking at path of treatment and place that they're getting their treatment. So in regards to pharmacy, a lot of the medications are running through the medical plan. So it's hard because we've put all of these clinical management programs in place on the pharmacy plan. But if you have, let's use oncology as an example. If you have a patient that's undergoing cancer treatment, some of the injectables are done in the doctor's office. And those go through the medical plan. So they miss the prior auth, they miss all of the key elements and key strategies we put into the pharmacy program. They miss some of those clinical step edits, we'll call them, in some cases where the site of care might be at a doctor's office or an infusion center or even the hospital. One of the other things that is something to think about is the specialty drug management. Some of the largest PBMs carve out specialty and they put it in a separate unit, and it really benefits the members, and it hopefully is benefiting you from a bottom line. But there's all kinds of things that you can do on specialty medication. Like, I'm a big fan of split first fill when it's available. And that means that when somebody is put on a specialty drug, they are given a half a month's dosage. They're charged half a copay. You pay half. But if it's a $10,000 drug, you're paying $5,000. They're paying half of their copay. And it allows the patient to understand whether they can work themselves through some of the side effects, the flu-like symptoms, even the injectable part, right? So I've not ever had to do a self-injection, but that would be traumatic for me and tumultuous, I have to say. That would be tough for me. So allowing the members to kind of jump over some of those hurdles before you give them a full month supply. There's all kinds of opportunities within the clinical management piece. So that's why I wanted to spend so much time on this slide. Plan members encouraging specialty pharmacies. That's, again, like ESI has a specialty branch that distributes the drugs. It's called a Credo. They actually will get the script. It will go to a Credo. Somebody will do the check to make sure that the doctor did the proper genetic testing to make sure that the person could actually metabolize the drug. They'll call the person and explain the handling, the refrigeration of it, the delivery, the administration of it, and really flu-like symptoms and things to encourage them to get through some of the side effects initially. So it's a good opportunity to have a specific unit manage those specialty drugs because they're so expensive. So Shannon, I'd love to get your insight on that, talking a little bit about the pipeline, the cost, and how it's differed in the last 12 to 18 months, and really what your take on the carrier, the new marketplace initiatives to help employers pay for these multi-million-dollar treatments, these genomic treatments that are coming to market, by either pulling them out of the self-insured risk pool and giving them a fully insured product with a PEPM. And then there's one stop-loss carrier that we talked a little bit about that has a fully insured option for this. And there's new emerging opportunities with new products coming to market about this, but I'd love to get your insight, Shannon.
Employers should be thinking about the overall increase in medication. Pharmacy already accounts for roughly 50% of spend, and while we've been preparing clients for this in the benefit world for the past 5 years, I think they still were holding out hope that this was just us consultants being a little pessimistic. Unfortunately, that's not been the case. Last year was the first time that I've seen in the industry that the standard benchmark pricing for AWP, average wholesale price, didn't have huge inflation across the board. But that did change as of 1/1 this year, with over 460 drugs seeing an average wholesale price increase of about 5%, and some of the most popular drugs on that list were about 7%. Humira was the most popular specialty drug on the market this year, and we saw that one actually go up by 7.4% in inflation. In addition to AWP inflation, we're also watching an extremely expensive pipeline for the near future. I've heard this once at a pharmacy conference, and so this is a quote, but it's honestly the best I've ever heard the pharmacy industry described. We're living in a Star Trek science with Flintstone distribution, and meaning we have some amazing life-changing medication coming to the market, but access and affordability are just not keeping pace. In the next few months, we will have the first gene therapies for hemophilia A and the first treatment for NASH, also known as non-alcoholic fatty liver disease. We also have the first cell therapy drugs hit the market in the next few months, which are going to be used for a few certain cancer treatments, specifically lymphoma. Those costs can be in the millions at this point. So the estimates for the hemophilia A medication is between 2 and 3 million. So as of right now, we know these are going to be significant costs to employers.
So we covered the low net cost as one of the key opportunities. And I have to tell you, like Shannon, I'm a big fan. I do believe, so the formularies, just to kind of take a step back and talk about formularies, but the formularies are basically the list of pre-approved drugs, or if there's 2 drugs that do the same thing, the PBM picks which drug is on the preferred list. It's kind of like what's on sale this week, right? So the PBM does a formulary list, and it changes, annually, if not more. Some PBMs change them 4 times a year. And the list includes, if you have 2 different drugs that treat cholesterol management, let's say, as an example, they'll put one of the 2 on the formulary, and it's less expensive for the patient or the member to get what's on the formulary than what's non-formulary. The problem, and where the PBMs have gotten accused of kind of rigging it so that the employer doesn't get the best pricing, is some of those, they're supposed to be driven, and they're supposed to be decided what drug gets on the list based on efficacy, how effective it is for treating that treatment, and what the price is. And unfortunately, they go after the rebates. So the drug manufacturer gives a rebate to the PBM for some name brand drugs. And this is a good slide because it gives you the example of the highest rebate, the first pill bottle of $980, isn't the lowest costing drug. It gives you the highest rebate, but it's not the lowest costing drug to an employer. So what we're saying is we should demand and push back on the PBMs to make sure that we are getting a formulary with the lowest net cost for the drug, not looking at just the rebate, but looking at, of course, efficacy first, and then the total cost to the employer second. So that is something that we all want to start asking our PBMs and looking at our contracts. Large employers have definitely are in favor of this pricing model, and large employers view net pricing approach as an alternative to just looking at the rebates. So we're going to move into prevention, and how do we know what to look for?
Welcome to Color. In this video, you'll learn useful information about genetic testing. Learning if you have an increased genetic risk for cancer can make a difference. Cancer is complex and has many causes. Most cancers are sporadic or seemingly due to random chance and without an identifiable cause. but about 10 to 15% of certain cancers are due to harmful genetic changes called mutations that are passed down through families. Color's hereditary cancer test is designed to detect mutations in a comprehensive set of genes associated with an increased risk for common hereditary cancers like breast, colorectal, melanoma, ovarian, pancreatic, prostate, stomach, and uterine cancers. Understanding if you have a genetic predisposition to certain cancers allows you and your healthcare provider to create a screening and prevention plan tailored to you. This is important because detecting cancer at its earliest stage improves the likelihood of a favorable outcome. While genetic mutations can increase risks for certain cancers, this does not mean cancer will definitely develop. A positive result or finding a mutation is not a cancer diagnosis and does not mean that you will develop cancer. For example, most women have a 10% chance of getting breast cancer by the time they are 80, while a woman with a mutation in the BRCA1 gene can have up to an 81% chance. Most men have a 2% chance of getting colorectal cancer by the time they are 70, while a man with a mutation in the MLH1 gene can have up to a 41% chance. The level of increased cancer risk differs from gene to gene. Even if your results show no mutations, you may still get cancer. While inherited mutations explain some cases of cancer, the majority are sporadic and can't be explained by a single cause. Some non-genetic factors that can influence cancer risk include environment and lifestyle, as well as family history without a known genetic link.
So that was a compelling video. When we started our session today, we talked a little bit about things changing more in the next 5 years than they have in the last 50. And predominantly it's because we understand the human genome and understand how our genetic makeup predisposes us for certain types of cancer and disease. Interestingly, employers across the country, especially large employers, are embracing covering the preventive genomic testing for their employees and their families, meaning they're covering the test. If a person goes to their physician, they can do the mouth swab, do the genetic analyzation, which is inexpensive today. It's under $200 or $300, and that will enable a person to understand their predisposition for some diseases, including cancer. This is changing our whole industry in the next 5 years to more of a preventive versus diagnosis and treatment. And if we look at our claims utilization, our high claimants, that's going to make a huge difference if we embrace that strategy and our overall cost and trend. Understanding your level of increase of cancer risk based on your genetic testing is something that I think, some employers worry about the privacy issues, but this is done with the patient and their physician, and the information is in their medical records and they're confidential. Employers are then using digital health solutions to kind of take that information or take that opportunity and do value-based plan designs with wellness and disease management programs with digital health solutions. It's also going to help with adherence. If you look at the cost of adherence, people that are on a chronic illness medication and aren't compliant or aren't taking their medication on time, again, that's another cost savings opportunity. We're going to talk a little bit about how adherence and diabetes go hand in hand as a key opportunity for employers, because it's one of our top drivers in cost, and it's an easy thing to find out whether what your average refill rate is. So it's easy to put value-based plan designs and digital health solutions in place. So the strategic investment in digitalization is really the whole spectrum. We want the people that are well with no risk to be using these things, as well as people with diabetes who need to manage their condition. Really cool technology. There's patches now for diabetics. The patches are wired to their smart device and can send them their glucose numbers and tell them that there's an adverse event coming because their glucose is not in line. Apple, the CEO of Apple has stated several media blitzes that Apple's greatest contribution to the Americans is going to be Apple Healthcare. They've created a watch that does a lot more than tell time. It's a phone, it's an EKG, it monitors your heart rate. Digital health is definitely here to stay. So there's all kinds of apps that if you look at your chronic illness bucket and create a value-based plan design and say to people that are suffering from congestive heart failure or heart that are on statins for cholesterol management and heart disease, there are tons of ways that you can design programs for them to get them into disease management. One of the things that we talked about in the last Power Lunch, and I feel like jumping on a soapbox and screaming this from the top of the building because I can't say how important enough this is, but employers are done with the carrier partner saying we've identified 170 people with diabetes and we have 5 people enrolled in our diabetic management program. It's nonsense. And we have to be, ready for change. I think it was Albert Einstein that said the definition of insanity is doing the same things over and over again and expect the same way and expecting a different outcome. And we really need to embrace a new frontier with digital health and really do value-based plan designs so that we're enticing people to participate in these life-saving, life-altering, cost containment disease management programs to manage chronic illnesses. And if you look at the chronic illnesses, 50% of America is suffering from a chronic illness, and that is going up. Chronic illnesses are a source of high cost for employers, and we need to wrap our arms around employer strategies with these. So 90% of healthcare goes towards chronic illness management, which is a strong reason for us to get behind this strategy. And you really need to analyze your data, right? We look at these things over and over and over again. It's heart disease, it's cancer, it's diabetes, and really looking at the cost of diabetes is staggering. The prevalence of diabetes continues to rise despite advancements, in treatment and programs. 36% of patients are non-adherent with their medicines. So we need to influence that with checking our adherence rate. I would venture to guess that if you sit in your utilization meetings with your carriers and say, what is our adherence rate for diabetics? They will probably say, I'll have to get back to you on that. And that is really something that we have to push as a change agent. And for diabetics, there's new science that's validated a new approach to treatment of diabetes, where in pre-diabetes, based on gut microbiome. So it's very interesting that there's new marketplace solutions that are integrating food as medicine to treat the disease. And precision medicine will really play a big part in that because they're going to look at your gut health and tell a person that the microbiotic gut health and put a targeted nutrition plan in place that will work with their medication. Diabetics, it's not only the second cost driver, but 28% of the increase in cost overall for those patients with diabetes. So they're 2.3 times more expensive than the average person. So we're going to tune in to hear a little bit from a new product, not really that new, but new to the market, Amazon with PillPack.
Did you know 150 million Americans take medication every day? So each person has to stand in line at the pharmacy, sort their pills, and remember to fill their prescriptions over and over and over. That's why we created PillPack. We're a new kind of pharmacy. We sort your medication by date and time and deliver it directly to your door.
But I take different kinds of medications at different times of the day.
No problem. We organize your meds for you, so now you don't have to waste time sorting your pills.
Sure, but can you do vitamins?
We can add those too.
But I hate paying for shipping.
Well, you'll love PillPack. Our service is free. You only pay for your medications.
And you take my insurance.
Yep. We work with most plans.
And you handle all my refills.
We work with your doctors to get you your medication every month.
What about my inhaler?
We're a full-service pharmacy, so we can handle your inhaler and any other pharmacy items. Every day, people across the country are saving time and staying healthy with PillPack. Switch to a simpler pharmacy today. PillPack.
So that was another compelling video. Hopefully, I'm not trying to sell PillPack or support Amazon in any way. I just think it's important as employers that we understand the digital opportunity, right, with some of the new technologies that are out in the marketplace to help our members be more adherent. It's difficult for people that are on multiple medications a day to maintain adherence and understand which pills to take at what time. Many people in the chronic illness bucket of our utilization are on multiple medications. And it's, anything to help them stay adherent and make it easier would be great. And there's all kinds of new things hitting the market, as we just saw with Amazon's PillPack, where they are trying to make it easier for people to be adherent. Some of the new technologies include these new smart contact lenses that are new to the marketplace. They are microcontrollers embedded in the contact lens that will measure the glucose level of a diabetic and send an alert 8 hours in advance to traditional paths of monitoring. And it can even send an alert to the person's caretaker or physician. So really great new technology on the marketplace. So we're going to move into kind of talking a little bit about the Tryon Pharmaceutical Coalition and some of the other marketplace changes that will help employers control costs and achieve better pricing in clinical programs. What is a coalition? It is leverage purchasing to achieve better pricing and better terms. So for those clients that are, maybe 500 employees or 1,000 employees that don't have the clout to go to a carrier and say, hey, we're going to do it this way. We don't want to do it your way. They found it hard, right? Because they don't have the leverage. So what we did was Tryon went out to the marketplace and we said to the biggest PBMs and the PBMs in the marketplace, we have 800 clients and we don't want to nitpick and go through each contract and change things one at a time. We outline, it took us 8 years, we outline what we want in our clients' contracts. Single source generics is a no-go in our contract. If it's a generic, the employer should get generic pricing. 90-day supply that Shannon talked about. So if they're pushing 90-day supplies, you should get 3 rebates for that in your contractual language, not 1. You're missing out on 2 rebates. That's a lot of money back that the carrier's holding. So really what we did with the coalition is we've said, it's pricing first, and then terms and clinical programs second, and then performance guarantees to make sure they deliver what they promise is kind of the 3-legged stool of our coalition. Some of the questions that I get asked a lot when we're talking about the coalition is, do I need to be self-insured? Yes, you need to be self-insured. And if you're self-insured on the pharmacy, you need to be self-insured on your medical because you need stop loss. And you can't get pharmacy-only stop loss in our marketplace today. There's no good options. They carve out the specialty drugs, which is the whole point of buying stop loss for pharmacy. So if you're self-insured, there's very, very large employers that don't buy any stop loss, but they don't buy stop loss on the medical either because they're so large. Will you lose autonomy of your plan? Nope. It's still a contract between you and the carrier. We've just pre-negotiated the terms for you. You can still use your PBM. In many cases, we're very incumbent focused unless there's something terribly broken. But we'll use our coalition pricing with your current carrier to make sure that we're getting you the best terms and pricing. And if we can get them to match our pricing in the marketplace with the coalition, with them keeping your business and keeping it, integrated or carved in, we're fine with that. I mean, we just want our employers to get the best pricing and the best performance metrics. Can you keep your current consultant? We would be the pharmacy consultant if you just used us for the coalition, but yes, you can keep your current consultant. And is Tryon a consulting firm, or do they represent a PBM? I think by this presentation, you can tell we don't represent the PBM. We are staunchly on the side of our employer partners. So we sit on your side to negotiate better terms for you, basically, in essence, against the insurance partners. But we're all in this together. We just want to get the best pricing, the best terms, the best metrics, and the best performance guarantees. And we do the initial data for analysis for free. So the key objectives are, just as I said when I kind of explained what the coalition is we go after price first and make sure you're getting all of your rebates and the best pricing and the single source generics and all that other stuff that might be in your contract that's not in your favor gets fixed. And then, of course, the clinical programs in the administrative performance metrics are the second thing that we take a look at, and that's ongoing. We quarterly meet with our clients to say, look at the utilization, what's driving cost, what clinical programs should we be thinking about. And those clinical programs you can grandfather. So it's not that you have to turn over the apple cart. You can make a clinical program change going forward. So saying if somebody's on a specialty drug, we're not going to touch them, but new prescriptions for specialty drugs need to go through the specialty PBM, a Credo, or depending on who your carrier is, we can tell you what the opportunities are on that. And then, of course, optimizing the clinical management pieces with performance guarantees, and monitoring and making sure that they what they promise they deliver to the client at the end of the year. So there's some carve out benefits. I know that the carriers will tell you that they like to have it stay integrated, but for all four of these reasons, we like carving out if you're able to. And again, we carve out to get better performance guarantees, better utilization management, better care management, more focused approach to managing what's driving cost on this very, very expensive piece of our medical programs. 50 cents on every dollar we spend for medical and pharmacy is focused on pharmacy. So we want to be looking at all four of these things. This is a sample savings analysis that we generate from the coalition. So you can see your in-force pricing and then our options, just to see what the savings opportunity is. It could be low, it could be medium, it could be a lot. And certainly we want to go after every penny, especially right now. So I wanted to turn it back over to Shannon just for a quick second to talk about what we look for in the contracts and how we try to pick out opportunities for additional cost savings for our employers. One of the things that I love about Shannon and what she adds to the team is the fact that she goes through the PBM's contracts with a fine-tooth comb. And there are always things that they add that never cease to amaze me, that these little tiny sentence changes can cost an employer thousands of dollars. One of them is that single source generic, which Shannon, if you can just talk a little bit about what you see on that. So the PBMs typically say that if there's only one manufacturer of a generic drug, you have to pay the name brand price, even though it's a generic. We've eliminated that language from our clients' contracts because a generic should be a generic and should be priced as a generic. So I'd be interested what Shannon has to say about that. Shannon?
Yeah, there's actually quite a few things that we're continuing to monitor within our pharmacy contracts. Something that we're seeing more recently come across is the encouragement of a retail or mail order 90-day supply on specialty medication. We see this as a major flaw in the contract because most contracts for specialty rebates are written to a per claim brand rebate. But what we're seeing is plans are being encouraged to fill a 90-day supply on these medications. But the PBM is forgetting to mention that you're not going to see an additional rebate dollar for this. You actually see fewer rebate dollars. So if a member goes to the retail setting and fills a 30-day supply of their specialty medication, you may get $1,000 as the plan. If the pharmacy fills a 90-day supply of that same medication, you will get $1,000 as the plan. So you're losing out on those 2 additional rebate claims that you would see if it were a 30-day supply versus the 90-day supply. We have one plan that received about $900,000 in rebates, but they left about $240,000 on the table due to this specific language. The other problem that we continue to see, and this isn't a new one by any means, is the single source generic language. We see a lot of plans come to us with single source generics still being included in their brand bucket. This does 2 things. One, it falsely inflates the brand discount by taking that lower cost, the lower discounted generic drug and shifting it into the brand. But it also makes it easier to hit that generic guarantee because they're removing that lower discounted generic drug into the brand bucket. A single source generic typically falls at a 40%, 50% discount, but it's definitely not going to hit the 75 to 80% discount that you see on the standard generic bucket.
So not sure where to start. If you're not sure where to start, just stay informed. Make sure that you understand what digital healthcare opportunities there are for your top afflicting diseases on your utilization report. Making sure that you review your plan design for every clinical management opportunity based on your spend, and really looking at the network and the formularies. There's opportunities there. And of course, clinical management programs like prior authorization, so that before somebody could get the most expensive drug, they have to go through the clinical step edit. They start out with the least expensive drug and then they move to the most expensive drug. Site of care, site of service, meaning the injectables, can they be done in a less expensive setting than a hospital? And of course, biosimilars are basically generic specialty drugs, looking for every opportunity within the formularies and the cost to really save money exactly where we can. We provide all kinds of opportunities for our clients, not only with pharmacy, but stop loss, voluntary benefits, communications, digital solutions. We have all kinds of news articles that get published on a monthly and weekly basis. So tune in. We do these power lunches every month. We love to do these with you, and we're going to get through this pandemic and be stronger for it for sure. If you have any questions, you can reach directly out to me. I do have a web page where I do a blog. I did comment on the executive orders that were issued in regards to pharmacy by the Trump administration. So that's in the blog on my webpage. You can read about that, what I think. mbgrayhealthcare.com, and we'll see you next month. Wow, I know that was a lot. Thank you for joining us for our hour session on pharmacy. I know it's a lot and it's confusing, and hopefully we demystified some of it. And I hope you all are leaving with, 1 or 2 ideas on how you can reduce cost within your plan and improve the quality of care being delivered to our members. Benefits are second to payroll. It's a very large business expense. I know it's very critically important for employers to be managing these costs. If anybody needs any help, we are here. Shannon, thank you for sharing your expertise and thoughts with everybody today. And if anybody wants to have us take a look at your current pricing compared to our coalition deals, we'd be more than happy to do that, and we don't charge for that. So our goal and objective is to make sure that we're providing good thought leadership to our employer partners, and we are making sure that you're paying an appropriate price and keeping the benefits affordable for our members and their families. Thanks so much for joining us today, and there will be a recording of the session provided to all the participants.